Okay, I think we can start, and I can continue admitting more people as they come. Thank you everyone for joining us today for this UIMS clinical series lecture. Today's topic will be endometriosis and laparoscopic surgery. With us today we have Dr. Nicolas Galazis. He graduated from the University of Nottingham Medical School in 2012 and has trained to obtain his residency in obstetrics and gynecology from various hospitals in London, training under many international experts in gynecology, ultrasound, surgery of both malignant and benign diseases, and has also trained in high-risk obstetrics. So I won't waste our time anymore. Thank you, Dr. Galazis, for joining us, and I yield the floor to you. I will stop my screen share now.
Thank you very much. Thank you. First of all, thank you very much, Cassandra, and thank you very much for the Union of International Medical Students of the Czech Republic for inviting me. And I do congratulate you for your great efforts. I've seen your accounts, your website, and you guys are doing a great job. And I do congratulate you as well for dedicating the month of April to women's health. That's very nice of you. And actually, yeah, not just the month of April, it should be something that we have very high on our agenda all the time. So what I'd like to do, I'm gonna give a lecture on endometriosis and laparoscopic surgery. That's the main topic today, but we'll also touch some other benign gynecological topics that are very, very common, and there are topics that people are asking me, friends are coming to me to ask me all these questions. So very, very common topics, and topics hopefully that you will find relevant to your learning as well, and hopefully whoever is watching to raise some awareness. Let me just try to share my screen. Cassandra, just tell me when if everything is okay. So I'm just gonna.
Perfect.
Slide. Is that okay now? Are you looking at my PowerPoint?
Yeah, we are looking at the PowerPoint, the first slide.
Excellent, thank you. So yeah, my name is Nicolas Galazis. I'm an obstetrician and gynecologist in London. I train in various London hospitals within Northwest London. Most of my training has been in the Imperial College Healthcare NHS Trust, which essentially encompasses St. Mary's Hospital and Queen Charlotte's hospitals. Two very, very well-known obstetrics and gynecological units in London. I've put there as affiliations Imperial College London, and Nicosia Polyclinic is my family's private hospital in Cyprus. So I always try to include my family's hospital. So just very quickly, a couple of slides about me. So I'm from Cyprus. I came to the UK in 2007. I graduated from the University of Nottingham in 2012. And since then, I did my foundation year 1 and 2 in London, and my specialty training in London as well. I've obtained my MRCOG in 2019. MRCOG is, I'm sure you guys are familiar because I know you are very, very clever, and you do host many people from the UK. It's a membership in the Royal College of Obstetricians and Gynecologists, as for the MRCP, MRCS, for the physicians and surgeons and so on. So I generally practice the broad spectrum of my specialty, obstetrics and gynecology, but I do have some special interests, which include laparoscopic surgery, minimal active surgery, as we also like to call it, gynecological oncology, fertility, gynecological ultrasound, and high-risk obstetrics. You guys, I think the new generation of medical students are much better than my generation in that you do try to publish a lot of papers I think when I was doing it, I was one of the very few that I was having publications from medical schools, but I know now is becoming more common, and yeah, it's a necessary evil. You have to play in all fronts, and you have to have a strong CV. So I've got a few publications. The topics are the topics that I generally like to read about and have special interest. I've also authored a chapter in a book on endometriosis, and 2019 was a good year for me. Before lockdown, we could still travel and go to conferences, so I made the most out of it. And the last thing that I'm doing this year, we founded a medical society in the UK, which is called the Cyprus Medical Society of the UK, where we try to bring all Cypriot doctors and medical students from the UK in a society where we can get to know each other and network and so on. So that's pretty much what I've been doing the last few years. Now, gynecology topics. I'm 34 years old. You know, my friends of my age are asking me about endometriosis, are asking me about ovarian cysts, are asking me about fibroids, are asking me about polycystic ovary syndrome, cervical smear abnormalities, and fertility problems. So we're not going to talk about cancer gynecology, because it's not something that I get to be asked by my friends, thankfully. Maybe when I get older. But essentially, we're going to talk about endometriosis, which is the main topic. Then I'd like to touch the topic of ovarian cysts and uterine fibroids. Now, some publications that you can see there, that's fine. Now, what is endometriosis? So, you are medical students. A lot of you may have done obs and gynae, and certainly you've done your sort of basic science and the physiology of the menstrual cycle and so on. On top, you can see my mouse. You can see my mouse. So on the top image here, we've got a schematic representation of the uterus, the fallopian tubes, and the ovary. And then you've got the cervix here, and you've got the vagina. Now, what is endometrium? The endometrium is the inner lining of the uterus. Yeah. So you've got myometrium, which is the muscle of the uterus, and you've got endometrium, which is the inner lining of the uterus. This endometrium is a very dynamic tissue. So in a woman's cycle, 28 days, this endometrium builds up, swells. It gets rich with nutrients and various proteins in order to accept a fertilized blastocyst, which will implant in this endometrium. When this doesn't happen, the body recognizes that, and this swollen sort of lining, this swollen tissue, comes out as a period. Yeah, and you've got this process monthly and presents as menstrual period. Now, what is endometriosis? Endometriosis is the presence of this endometrial tissue, but I call it ectopic endometrial tissue in the sense that it is the presence of endometrial tissue in the wrong place, outside where it should be, outside the uterus. So this endometrial tissue can be deposited anywhere in the pelvis, in the surface of the peritoneum in the pelvis, on the ovaries, on the fallopian tubes, on large and small bowel, and so on. Why is this significant? Because this process, when it happens in the uterus, in the endometrium, so the utopic endometrium, so the endometrium that is in the right place, when this happens, it's fine. The endometrium sheds, comes out through the outside world as menstruation, and that's it. However, when you have this endometrial tissue somewhere else, the same process will happen. There will be shedding of this tissue, there will be bleeding, but obviously the bleeding occurs inside the body. So it occurs inside the pelvis, and this presents as pain. Blood is an irritant to the pelvic peritoneum, and therefore when you're having the period and you're bleeding vaginally during the period, They're also bleeding internally, and this is causing pelvic pain. So that's very in a very simplistic term the why we get pain and the pathophysiology of endometriosis. Very common. It does affect about 10% of women, of young women of childbearing age. And sadly, the average time of diagnosis from the onset of symptoms is 8 years. So a woman suffers for 8 years before until up to the point where she actually seeks help, goes to her GP, goes to a family doctor, who refers her to gynecology, and endometriosis is diagnosed, as I said, on average 8 years later. So you can imagine the stress, the disability, and the burden that endometriosis can cause for so many years before it gets diagnosed. And that's why there is huge campaigns over the last few years. It has become quite fashionable now to people to talk about endometriosis. And indeed, we have to try to raise awareness about endometriosis because it's an undiagnosed condition that can be treated, and so common. It affects so many young women, so many women that the last thing that they want to do in their life is to suffer. There are women that are in universities. There are women that want to pursue a career in their profession, and there are women that want to start a family and they're suffering. So that's not acceptable, and of course that's why a lot of effort has been put on awareness. Now, there's a lot of, if you open a textbook, there's a lot of theories why endometriosis develops, but nothing is proven, and really the overall cause, the cause is unknown. But the main, probably the main and a logical explanation is the theory of retrograde menstruation, which was initially stipulated by Samson, who was a gynecologist. Now, retrograde menstruation, as you can imagine, so you can have menstruation where the blood comes out through the cervix and the vagina, but you can have retrograde menstruation at the same time, where some of that endometrium and some of that blood, instead of coming out through the vagina, it goes back in the abdomen through the fallopian tubes. And you can imagine, it does make sense that if you have the deposition of blood and endometrial tissue in the pelvis, first of all, you're going to have pelvic pain because, as we said, blood is an irritant to the peritoneum, to the pelvis, and of course you can have deposition or implantation of this endometrial tissue inside the pelvis, which again can undergo the cyclical process itself and happen every month without having any further retrograde menstruation later on. So you've got deposition and implantation of this endometriotic tissue in the pelvis that has the cyclical process because of the hormones. Risk factors. So again, as I said, causes unknown. There are some risk factors, weak risk factors and associations. We tend to believe that nulliparity, so not having children, we find endometriosis more common in this population, and we think that there is a bit of a genetic component in it, although it's multifactorial. There's no gene that you inherit and you get endometriosis, but it is rather multifactorial. So it does run in families. We see that a lot of the times. Women will tell us, "Oh, my mother had that, my sister has that, and so on." Now, in terms of symptomatology, as I said, the main symptom is pelvic pain, which and characteristically this is cyclical. So you've got painful periods, which we call dysmenorrhea, and you can have painful intercourse as well, which we call dyspareunia. As endometriosis progresses, endometriosis is an inflammatory process. It can cause fibrosis, adhesion formation. So this cyclical pelvic pain can actually become chronic pelvic pain and sort of non-cyclical or sort of constant pelvic pain. But initially, it's typically cyclical, and And when we hear that, we've got a very, very high index of suspicion that, that this woman may have endometriosis. Now, less commonly, you have bowel symptoms as well as urinary symptoms. And again, typically these will develop, will be seen or will be experienced during menstruation. So you'll have difficulty of opening bowels, which you call dyschezia, and difficulty or painful urination, which we call dysuria. Women may have also heavy menstrual bleeding, menorrhagia, and endometriosis has been associated with subfertility or infertility. Subfertility, difficulty in becoming pregnant, infertility, unable to become pregnant. In fact, in the fertility clinic, we find that about 40 to 50% of women in the subfertility or infertility clinic have endometriosis, although it doesn't necessarily mean that this is the cause of their infertility. As I've implied earlier on, you can imagine that this condition has a significant impact on the quality of life and mental health of the woman. And that's why we're talking about awareness, and that's why we're doing this lecture today. And that's why I'm grateful, and that's why I'm congratulating you for dedicating the month of April to women's health. And we have found that sometimes when women have their first child, obviously when they're pregnant, the whole process is put to a halt and you don't have endometriosis because it's a cyclical hormonal process, and pregnancy stops periods and stops this process and stops ovulation. But we do find that even after pregnancy, when periods resume and the body goes back to normal, the symptoms of endometriosis improve. But again, we don't quite understand that, and it is an association, but it's quite a strong association. It's evidence-based, although we're not exactly sure why this happened. Now, diagnosis, awareness. So good history. So I've told you the symptoms of endometriosis. So if you take a history, you will be able to elicit those symptoms. And therefore, if you know your facts, you will be able to have a high index of suspicion that this patient has endometriosis. Of course, you won't be able to diagnose it, but you will take a history that is suggestive of endometriosis. Examination. If a patient has a large ovarian cyst secondary because of endometriosis, or what we call chocolate cysts or endometriomas, it can be felt on abdominal examination as well as on bimanual vaginal examination. Also, during bimanual examination, you can feel nodules of endometriosis in the vaginal fornices, consistent with rectovaginal endometriosis or endometriosis or nodules in the uterosacral ligaments, which again feel firm on vaginal examination. But that's the sort of a very, very useful history examination. But of course, we've got technology, we've got imaging, ultrasound, and MRI. Now, ultrasound, we can very, very easily diagnose ovarian endometriosis, so endometriomas or chocolate cysts. They're all the same thing. And recently, as technology and expertise and better ultrasound scans are being used, we can actually diagnose some endometriosis as well, non-ovarian endometriosis. So we can diagnose endometriosis, endometriotic spots in the rectovaginal septum. We can assess for mobility of the genital organs, so we can assess mobility or adhesions between the uterus and the rectum posteriorly, or for adhesions anteriorly between the uterus and the bladder. So there are some signs that we can elicit through ultrasound scan. And MRI is a more sort of accurate modality, obviously more expensive, less readily available. Ultrasound scans, as gynecologists, we do it all the time. So MRI is another modality that can clarify situations and can assess the extent of deep infiltrating endometriosis and so on. And then, of course, we've got laparoscopy, which is the gold standard for the diagnosis, where we actually go in with a camera and we visualize the pelvis. Obviously, from experience, there are certain areas within the pelvis where you can where endometriosis is seen more often, and therefore we have a systematic approach, and we look for endometriosis, and of course we can excise these lesions and we can treat the endometriosis. And of course, once you've excised the lesions, we always, whatever we do, whatever we take out from the body, we send to the lab, and the lab will confirm endometriosis. But macroscopically, so laparoscopically, with our eyes or with the camera's eyes, that's enough to know that this is endometriosis. Ultrasound scan, so ovarian endometrioma looks like that. So when you say, when I put there right, I think it says right at nexa there, you can have this characteristic ground glass appearance of the ovary. So because it's all blood, which has a heterogeneous echogenicity, let's say, so it appears like a ground glass appearance, and that's the characteristic endometrioma. So it's fairly easy to diagnose preoperatively by ultrasound without doing a laparoscopy. Now, treatment. So we said symptoms, pain, mainly pain. We'll talk about fertility problems as well. So how do we treat pain? Painkillers. Non-steroidal anti-inflammatory medication, such as ibuprofen, naproxen. We can use some paracetamol as well. We can use mefenamic acid, Postan. And we try to avoid opiates just because it can cause constipation and so on. So we try with NSAIDs and paracetamol. Now, in terms of further medication, hormonal medication, this hormonal medication essentially is the contraceptive medication. They usually work by inducing ovulation, so they stop this monthly process and therefore prevent the process of endometriosis happening and prevent this shedding and bleeding in the pelvis. So we do find it very, very common to prescribe the combined oral contraceptive pill or the mini pill, also known as Cerazette or Desogestrel, or the Provera or the Depo-Provera injection, or the Mirena coil or Levocert or levonorgestrel intrauterine system, whatever you want to call it. This will will inhibit ovulation, and therefore will inhibit the pathophysiology, the process of endometriosis. And we do find that this is very common. And you will hear a lot of people, I had my period, now my periods are not painful. And they haven't been diagnosed of endometriosis, but you hear that very, very often. Even interestingly, sometimes when we are not sure if this person has endometriosis, we will give them the pill, and if it has worked, then it's sort of a trial of it gives you the diagnosis. So it worked because there was endometriosis. So it has a diagnostic value as well. GnRH analogs are injections, hormone injections that switch off the whole hypothalamic pituitary ovarian axis, and again inhibit the whole process. And of course, then we move into surgical management, which is laparoscopy, visualization, and excision or ablation of the lesions. And very, very rarely, when everything else has failed and when conservative laparoscopy has failed, we can do pelvic clearance, which means that we remove the ovaries, we remove the fallopian tubes in the uterus as a last resort, but it's not something that we do often. In terms of what is best, excision or ablation, there is a trend towards excising the disease. So when you see the spots of endometriosis, you just excise them as opposed to ablating, burning them. And of course, the other benefit of excision is you actually obtain a sample that you can send to the lab as opposed to destroying a sample during laparoscopy by ablation. You obtain a sample and you send it to the lab, and that can confirm the diagnosis, although, as I said, laparoscopy is good enough to diagnose endometriosis. Excision or ablation, again, depends on the size of the lesions, of the anatomical area of the lesions, the operator's experience, and so on. And then going back to treatments, I've put assisted reproductive techniques, IVF. So if the patient's problem is subfertility, then you treat subfertility, you don't treat pain, and treatment of subfertility could be some fertility treatments. Now, so that's what I've been trying to say. So treatment is individualized. So it depends on what symptoms the patient is having, what is the issue. So if the issue is pain, painkillers, hormonal therapy, surgery. You can give GnRH analogs to reduce preoperatively or neoadjuvantly, although it's not correct to use that term because we use that term for cancer, to reduce the bulk of the disease, reduce the inflammatory process of endometriosis, and then 3 or 4 months later, you do the surgery and you find that the pelvis is calmer, there's less inflammation, which means there's less bleeding, and the surgery can become better. And of course, post-operatively, adjuvantly, again, now I'm taking the piece, I'm joking, you can give hormonal therapy, so the pill, for 12, 18 months, because we know that this reduces recurrence of endometriosis. Endometriosis generally, and again, it depends on the age of the patient. If you are operating on endometriosis in a 20-year-old, unfortunately, this is a very young girl, probably endometriosis, she's got a lot of time ahead of her before menopause. So unfortunately, endometriosis might come back at some point. Obviously, if you're operating a 40-year-old, you're hoping that that's the first and last operation that she's going to have. But there is a recurrence rate. And we know that by giving post-op hormonal therapy, such as putting a Mirena coil at the end of a surgery, or giving the progesterone-only pill, so the Sogestrel or Cerazette, or the combined pill, can reduce the recurrence. We know it works. And of course, if the issue is fertility, surgery can improve spontaneous and assisted pregnancy rates. And if we're talking about assisted pregnancy rates, so you do surgery and then you can proceed, so plus minus IVF or whatever. Counseling is very, very important. Women come to our clinic and they're desperate to have an operation, understandably, because they're suffering, because they have too much. However, we have to get them to take a step back. We have to counsel the patients. We have to remind them that this is potentially a complex surgery. There is a risk of injury to nearby organs, such as the ureter, the bowel, especially with endometriosis, because I don't know how much experience, what you have seen in terms of endometriosis surgery, but you do get cases of frozen pelvis where everything is stuck together with a lot of adhesions, inflammation, and fibrosis. And so these surgeries tend to potentially can become very difficult. So it's counseling and explaining the advantages and disadvantages of surgery, explaining all the options, and guiding the patients to make an informed decision, and you support them in that decision. Obviously, age is a factor. Their wish for fertility or not, whether they complete the family or not, is very important, because you can just treat endometriosis by just fitting a Mirena coil, which can be good enough treatment for endometriosis, but of course they won't be able to have children because it's a contraceptive device as well. So does the patient want to have children? No, okay, we can try. Yes, unfortunately, it won't be an option. So treatment is individualized, and you have to go through all the pros and cons. Now, we always say this surgery, as I said, because it's potentially complex surgery. In the UK, I don't know how it's in the Czech Republic, is reserved for tertiary units, so endometriosis centers, where there's a multidisciplinary team of gynecological surgeons, urologists, colorectal surgeons, obviously radiologists with interest in gynecology, in gynecological organs. You've got pain teams, you've got endometriosis specialist nurses, you've got fertility teams, and so on. So it needs to be done in a tertiary center. Now, some pictures. So these pictures and videos that I'm going to show you, I've collected only a few weeks ago when you guys have asked me to give this presentation. So I wish, retrospectively, I wish I was collecting cases and images from forever, because I would have had an amazing library, but I will start from now anyway. So this is a recent case that we did. Was actually done as an emergency case. She came, it wasn't an elective case, so she came with abdominal pain. We did scans, we suspected endometriosis. The pain, the woman was in such a significant pain, so we just did under the sort of the emergency list. And you can see we went in, that's the, oops, sorry. That's the, sorry, that's, where is my mouse? There is my mouse, okay. So, so this is a view that we see the camera, we're looking towards the pelvis, and you can see, I'm losing my mouse. So left ovaries, you can see is distended, is full, is big, and it has an endometrioma. You can see the left fallopian tube around the ovary. You can see the uterus at the back there, and you can see the right fallopian tube and the right ovary, which are normal on the right side. You can see some bowel. And here is what we call the pouch of Douglas, or with American books, I think it's called, we stopped calling it a rectouterine pouch or whatever it's called. And you can see that there is a bit of blood, a bit of old blood there, which you know is this retrograde menstruation that I was talking about. And then once we tried to mobilize the ovary, we ruptured it, and you can see this characteristic chocolate material there. Now, again, before the rupture of the cyst, some closer looks. Again, you can see the left endometrioma, right ovary there, pouch of Douglas, and you can see that there are some spots of endometriosis in the pouch, and some sort of angry-looking bands, inflammatory adhesions and processes, and some vascularization there. So the whole area is angry. You touch and it oozes, it bleeds easily. So so it's not a friendly place to be. And now I'm going to show you some videos. That's my challenge. So you will tell me, Cassandra, if I will be successful in that. So let's see.
Of course.
This is not. I don't want to show you that yet. Okay, let me go back. You are allowed to have a break when I'm. Okay, so let's see.
I think first you should stop sharing your screen, because we can still.
Let's stop and go start from the beginning. Okay. So let me stop share. Then can you hear me? You can see me now, not anything else. Okay, so share screen, and then okay. So we've got this video, which is the third video that I want to show you. So if I go there, oops. You won't be, we're gonna, you can't, do you see that, Cassandra?
We can only see the files, the different files.
Okay, gotcha, okay. So stop share again. And now, because I've opened it, so, okay, I think that's the one. Now you can see this video?
Yes, we can.
So I've got 3 videos of the same case that you've seen the pictures, and I said this is a recent case. So 3 steps that I want to show you. I hope it's not disgusting, and please tell me if it's disgusting. Please tell me to, yeah, okay. So so 3 videos, 3 steps. First, we rupture the cyst, we drain it, we debulk it, then we try we try to remove the cyst wall from the ovary, and then we achieve hemostasis, we check for hemostasis, and we suture back the ovary. So this is the first step. We already ruptured this ovary, so you missed that. We didn't video it. So you can see with the suction, this instrument here is a suction irrigation. We're just irrigating fluid, and you can see that there's chocolate cyst content still coming out. And we can see with the sucker again, bluntly trying to separate and mobilize that ovary. You can see that's not the normal anatomy that you will normally see. So everything is stuck and adherent to each other, and we're trying to mobilize that ovary from all the other structures before we perform the cystectomy. And again, we're trying to make sure that the cyst is drained before we perform the cystectomy. It's a messy video, this one, but hopefully the other ones will be better. But this is endometriosis surgery for you. I mean, this is a messy, complex, difficult surgery. So let me now, I'm going to stop share again. I am going to put the next one. Then I'm going to no, okay. There's something wrong. Can you see me now, guys?
Yes,
or
see you.
Just me? Yeah. Okay, that's fine. All right. So share again. Okay. Video number 2. We've drained the video. We've drained the ovary, and now what we're trying to do, we're trying to separate the ovarian tissue, which you see there, from the cyst. So this is the cyst here. You can see my mouse, and here we're grasping the ovarian tissue. We're trying to separate the cyst capsule or the cyst wall from the normal white, this area here, which is the ovarian tissue. And it's a slow process. We have to be patient. A lot of passing from one instrument to the other. This is laparoscopic surgery, where everything looks clumsy, but it is really difficult to operate with these sort of long instruments, and it requires very good hand-eye coordination. You can see as we're separating the cyst from the ovarian tissue, and we're approaching towards the midline or the hilum of the ovary where the blood supply is. There will be invariably some oozing, some blood, and using our harmonic instrument, we're coagulating these oozing points and at the same time we're bluntly dissecting the cyst wall away from the ovary. So a bit of coagulation there as well, where we have to be very, very careful not to overcoagulate, because overcoagulating means that you can reduce the ovarian reserve of that person, of that ovary. So it's achieving the white balance. So you can see not a lot of coagulation, not just a couple of seconds every time. And again, blunt dissection, trying to separate the cyst from the ovary. And again, as you're going more in the base of the cyst, this is the infundibulopelvic ligament and the ovary there. So the blood supply to the ovary is there, and invariably it will bleed, but we just take our time. We're coagulating as we go. And there's a bit of bleeding there, and that's fine. That's a good case of how you separate the cyst from the ovary. And I'll show you the final. Okay, now stop share again. Screen sharing has stopped. Okay, have I stopped? Yeah. Okay. Let me show you the third final video, and then we'll do some more slides. So I hope you're finding it. I hope I'm not boring you.
Not at all.
So, okay, start sharing again. That's the third video. So what you can see here is we've put this powder area is a hemostatic agent. So we put this powder on the surface of the ovary. Now, as the cyst has gone, this is just the ovary, just to reduce the oozing, and at the same time we're suturing this ovary back, so that again it's it back. You're applying a bit of pressure, so hopefully it will work with the bleeding. So it's a hemostatic process. There is a debate whether we should be suturing or not suturing the ovary. I think it makes sense to suture it. If we were doing open surgery, we would have sutured it. So if we were, if we would be suturing it during open surgery, then why not suture it during laparoscopic surgery? So it's fiddly, it takes time, needs practice, but it's better, I believe, to suture it both hemostatically and also, especially when you have such a big distended ovary from that large ovarian cyst. If you leave that surface open, that's my opinion. Probably is not evidence-based, but in my mind, it does make sense that if you leave that low area open, it will probably cause more adhesions in the pelvis, and naturally this tissue will find somewhere to stick in order to heal. So I believe that it will cause adhesions. So that's suturing, and that was the case. So now I've stopped. Okay, now I need to go back to my presentation. So it was initially I put these videos on the actual PowerPoint, but it was a 3 GB PowerPoint presentation, and it will crash any computer that I will open it. So I put them separately. Okay, so that's the 3 videos that we've seen. Now, a bit of more gynae. Ovarian cysts, so a couple of slides, and then a couple of slides on fibroids. So ovarian cysts, 10% of women will have surgery in their lifetime for an ovarian cyst at some point in their lifetime. And I think the number of women having, well, all women have ovarian cysts. They have functional cysts that you form cyclically during your periods. So it's a really, really, really common finding to scan someone and find some ovarian cysts. Indeed, the guidelines, the RCOG guidelines for simple cysts in premenopausal women says that if you find a cyst that is less than 5 centimeters, you don't even need to follow it up. Now, in practice, it sounds a bit harsh, and in practice, we don't follow that. We don't follow these guidelines. We do give follow-up to women with a 4 centimeter ovarian cyst. However, so it's not necessarily what we do in practice, but what I'm trying to tell you is that they make this guideline to show the point is that it's so common, it's so innocent, it's so benign, and the vast majority of them will resolve spontaneously within a couple of cycles. Now, if you have a cyst that is between 5 to 7 centimeters, they're still not very bothered, and they say, oh yeah, okay, let's do a follow-up in a year's time, which in reality, I'm sure as patients, they will want to have a sooner scan. The huge majority, obviously, are benign. Only 1 in 1,000 are malignant in young women. And when you approach the age of 50, about 3 in 1,000 are malignant. But of course, postmenopausally, then we become more suspicious. And as I said, the majority of cysts are simple and resolve spontaneously, so no surgery is needed. Now, this table is a copy-paste from the RCOG green top guidelines for ovarian cysts. So, so I just cropped it. So there's many causes of adnexal masses. You can have ovarian masses, which can be various types of ovarian cysts, endometriosis, endometrioma, as we've seen, mature teratoma, also known as dermoid cyst, which I'm going to show you in the next couple of slides, and various other cysts. You can have malignant ovarian cysts, and you can have non-ovarian adnexal masses such as tubal cysts, paratubal cysts, hydrosalpinges, even pedangulated fibroids that resemble like ovarian in origin, appendiceal masses, and so on. There's a lot of things happening in the pelvis, essentially. Now, some scans. So this is what we will call a simple cyst. So it's a big cyst, it's about 8 centimeters, but it's simple in the sense that it's black. It has clear fluid. It doesn't have heterogeneous material. It doesn't have blood inside, as opposed to the endometrioma that we've seen earlier. It doesn't have solid components, which will be a suspicious finding. So this is a simple cyst. It's an 8 centimeter cyst. So in this case, we will recommend that we do surgery, just because, although we will offer surgery at the least, depending on the symptoms as well, but we should definitely offer surgery because at this size, there is always a small risk of torsion of the ovary. Torsion of the ovary, of the cyst and the ovary, means that the ovary is torted around its pedicle, which is the infundibulopelvic ligament, which contains the gonadal or ovarian vessels, and when this happens, it can cause strangulation and subsequently loss of the ovary, which I will show you in a bit. I wanted to. This is the best. This is not polycystic ovary per se officially, because it has to, I think the definition says that it has to be 12 sub-centimeter small follicles, and clearly this is not 12 here, but it's a PCO-like kind of, because as I said, I don't have a huge library, but that's how a PCO, a polycystic ovary, will look, obviously with more follicles, and we characteristically say that it resembles like a necklace of pearls. So you've got the follicles that are around at the surface and not the inside. So it will be like that: follicles, pearls around, and they are sub-centimeter. As I said, this is not. Let's be correct and not call it a polycystic ovary. Now, it's a case that we did in Cyprus actually. So. We had a case, we're actually not 100% sure whether it was a dermoid or something more nasty on the scan. But of course, when we did the procedure, we could tell laparoscopically that it's a dermoid cyst, and therefore we didn't do an oophorectomy. We just did a cystectomy. And then the specimen had hair and teeth, which you cannot actually see there. It had cartilage, teeth, and a lot of hair. And essentially, dermoid cyst is what we call a mature teratoma, which means that it's an embryological origin of ovarian cyst that contains all the layers of all the embryological layers, including endoderm, mesoderm, and ectoderm. And that's why you get ectodermal stuff when you see the specimen. It's quite cool when you show it to medical students. Now some more images. So this was a case. It's actually a case from St. Mary's. So a year ago, it's one of the few pictures that I've saved on my phone. So this was a very rare case of what we call a Brenner tumor. So it's a benign ovarian cyst. But it's not a cyst actually. It's the whole ovary was just taken over by this mass. And then you've got here borderline ovarian tumors. So these are tumors that are they are not benign, they're not frankly malignant, but they do have some malignant potential, and that's why we call them borderline ovarian tumors. It's a big topic. There've been a lot of papers on them, and I was very lucky to have worked with people that I would say they're probably world renowned on this particular pathology. So I had quite a bit of exposure on this pathology. Now, ovarian torsion. So this is very, very recent case that I did. I was on call. I was actually so it was in the middle of the night, this operation. Young girl, 25, with abdominal pain. We did, I think initially came under the surgeons, the general surgeons. They did a CT scan. They found this ovarian cyst, so they told us that's you guys now. That's fine. So so she had this massive cyst that looked tortured. Obviously, it's difficult to say from the scan. So we had to go in because she's young. We don't want her to lose her ovary. We go in, and everything is inflamed. Everything is nasty. You can see this exudate and inflammatory fluid. You can see the uterus here, which was adherent to the anterior abdominal wall, and you can see this dead purple ovary here. It's a left ovary. This is the right tube that is normal, but it's a bit hypertrophied as well. It's a bit inflamed. And then we separated the anterior wall, and you can see the fluid collecting in the uterovesical fold there. I'm demonstrating here a normal right tube and ovary. You can see the right ovary, right tube, and this is the left dead ovary, which is taking all over the abdomen. And then on the next picture, we found the point where, so this is the pelvic sidewall here of the left ovary, and that's where the pedicule was torted, and I had to untort it 3 times. And we've got the bowel on our way as well, which it was very annoying. So we had to separate it and get a better access. And that's the bowel now off our view. We see the infundibulum pelvic ligament. That's a detorted tube ovarian complex with a dead fallopian tube and a dead ovary. And you can see, I mean, this is unfortunately not a viable organ, and unfortunately we had to remove it. Fibroids, leiomyomas. Lyo, fibrous tissue, myoma, muscle. So they are muscle, they are fibromuscular muscles. They are benign. About 1 in 500 cases when we do a hysterectomy for fibroids, it turns to be sarcoma. So we get back a cancer diagnosis, but the vast majority are benign conditions. Very, very common. 1 in 3 women have it. So meaning that if I scan 100 women, 35 women we will see fibroids. But usually they are small size fibroids. We don't do much about, and we can manage them conservatively. We don't know really why this is happening, but we think that is related to estrogen. And we have seen that in obese women is more common due to high estrogen levels. It's also more common in Afro-Caribbean women. Different types of fibroids, depending on the anatomical location. You can have what we call submucosal fibroids, which grow inside the endometrial cavity. You've got intramural fibroids, which grow in the muscle, in the myometrium, and you have subserosal fibroid, which develop outside the uterus, attached to the serosa, to the uterine serosa. So symptoms, typically, so first of all, asymptomatic, very, very common. Women have fibroids and they don't have any symptoms at all. Now, if they have symptoms, the commonest symptom will be heavy periods and sometimes painful periods. You can also have abdominal pain or pressure symptoms such as urinary frequency if the fibroid is anterior and pressing on the bladder, or you can have constipation if the fibroid is pressing on the bowel. Diagnosis is by abdominal palpation and examination, sometimes by manual examination as well. But typically, you palpate and you feel like a uterus up to the level of the umbilicus, or sort of infra-umbilical or suprapubically. So they distend essentially the uterus and make it an abdominal organ, essentially, instead of a pelvic organ. You can do an ultrasound scan to see them, and of course, MRI can diagnose fibroids. So treatment, again, depending on the symptoms, but if the symptom is heavy bleeding, it can be sometimes managed just by hormonal medication or other medications such as tranexamic acid or mefenamic acid. But of course, depending on the size, the location of the fibroids, we can offer a surgical treatment which can be hysteroscopic, so through the cervix and inside the uterus. If we think that the fibroid is what we call submucosal, so growing inside the cavity, or we can do abdominal surgery, whether that's by open or laparoscopic surgery, to remove fibroids on the muscle of the uterus that can be accessed from the abdomen. And here we've got some nasty, some disgusting pictures of fibroids, all recent, 30, about 25 centimeter fibroid from a uterus. A lot of other, I think there we removed about 20 fibroids, and this is a single fibroid in Cyprus, the size of baseball, I suppose. Now, these are two again, recent cases from hysterectomies, these cases. So we didn't bother doing a myomectomy, which is removing of fibroids. Also because the patient obviously has completed her family. She was at an age where, her uterus, she was happy to let go of her uterus, and we had to remove huge uteruses. I mean, this uterus was taking the whole abdomen up to the xiphysternum, really. And I said, when we put the ruler, I mean, it was this distance was over 30 centimeters, and it was big. And this is a uterus, again, that when you incise it, you can see all these small fibroids inside the muscle of the uterus. So it's a distended uterus that contains many fibroids. So last couple of slides. Cassandra, you didn't ask me to do that, but I've seen that you guys are interested in training in the UK, and your angle, you've got this angle. So as you know, F1, F2. I know you guys. By the way, I've got quite a few friends that have graduated from universities from the Czech Republic, who are my colleagues and friends, and they do very, very well in the UK. So I know that you guys can skip F1 and you can enter as F2. I might be wrong. You guys will know better, but okay. And then of course, once you get into the system, you apply for specialty training. Obs and Gynae, 7 years. The good thing with Obs and Gynae is that it's what we call a run-through specialty, a run-through admission process, as opposed to medical specialties or general surgical specialties where you do core medical training or core surgical training for 2 years. Then you have to reapply for ST3 to 7 or ST3 to 8. Depending on the specialty. So in Obs and Gynae, as well as other specialties like pediatrics, I think ophthalmology is run through. So you apply once, you get the job, and you're sorted. You don't need to reapply and so on. It is competitive. It depends where you want to do it. London tends to be always more competitive. Obviously, once you get the job, as at the training number for 7 years, you rotate in different hospitals within a certain region. I said I'm rotating in central London, sort of or West London hospitals. It depends on the region, so you know that you're going to be working for the next 7 years in these sort of 4 or 5 hospitals. Then towards the end of the training, you can train, you can acquire advanced skills, you can develop special interests, specialty training, fellowships, and so on. And the good thing with Obs/Gynae is that it's a very, very broad specialty. You have a lot of medicine, you have a lot of surgery, you can do obstetrics, you can do gynecology, you can do everything. There's certain subspecialties which you can pursue. So it's really attractive, and I think it's a really, really good option for every single type of personality that you are. There's some specialties that you have to be this kind of personality to do that. Obs/Gynae, because it's so broad and you can do so many different things, whoever you are, you can do Obs/Gynae, or you can succeed in Obs/Gynae. As it is 7 years training, it's competency-based system, so you have to complete this, you have to do this procedure, you have to be signed off for this procedure, and so on. You have a portfolio that you have to, can be tedious, it's a bit of a tick box exercise, it feels many times. And you have to do annual assessments to progress the next year. And of course, you have the exams, as with all specialties. MRCOG is 3 exams, and then you're done. Laparoscopic surgery, you need a lot of training, a lot of playing at home with boxes and do practicing suturing. It takes time. It does take time. You have to go to courses. It depends on the level you want to achieve, but you have to go to courses. You have to spend a lot of time alone, practicing your skills. But it's great. You get to travel as well. You get to go to conferences, see friends, get to operate with your father as well back home. It's my favorite picture. And you get to train. I mean, this was a trip to Germany where we train in Johnson & Johnson's or Ethicon's factory on live pigs. So you get some fun stuff as well, and hopefully, obviously 2020 wasn't a great year, but hopefully 2021, 2022 will be a better year. Obs/Gynae is great. You deal with healthy and young patients mostly. Happy specialty. You get to deliver babies, you get the odd nice wine or champagne, and you get some nice letters as well. So that's it. So I'm just putting Cyprus Medical Society and the website and the social media, just because you're medical students and we do a lot of things for medical students. Do follow. Yes, a lot of the times it's Cyprus based, but it is really useful for everyone, and we do get a lot of cool people to talk to on our events. Not as often as you guys do. You guys are amazing, but we do try to do a webinar every few weeks. And that's my email. I'm very happy to be contacted by anyone. You can find me on social media as well. So thank you very much. I'm very happy to answer any questions. I'll stop talking now.
Thank you very much.
The longest talk I've ever done in my life.
Thank you very much. Before we continue to the questions, if it's possible for me, I'll share my screen as well.
Yeah, sure.
We are having, as Dr. Galazi said, the month of April for women's health. We have a pretty busy schedule the next few days. You can see here all the upcoming events, and we would be very, very happy to see you in the rest of our events that are coming up. For now, let's continue with a few questions in the private box chat. So maybe I can tell them for the rest of the people. As we saw during the second video, I think, of the surgical procedures, someone asked, what are the fertility implications of the suturing back the ovary together? Yeah, so actually, suturing back, it's a good thing that we're thinking about fertility when we do ovarian cystectomies, first of all. So that's very good thinking. So we are in the right direction. So suturing doesn't affect fertility. So it's not a destructive process to
diminish the ovarian reserve. I suppose we shouldn't be, it's not a very hemostatic suturing, so we don't necessarily need to suture very, very tight, because that can cause, theoretically, I doubt it, but theoretically you can argue that it can cause a bit of necrosis and a bit of diminish the blood supply. But other than that, it's not a destructive process that should diminish ovarian reserve. What does, but it is a good question, because coagulation, which I've mentioned, can affect ovarian reserve. And that's why we try to minimize it. And it's better to actually suture to achieve hemostasis rather than overburn that ovary to achieve hemostasis, because you might be causing damage.
Thank you very much. We just got another question in the box chat. It says, can we talk about the cure for endometriosis or just treatment? And do repeated surgeries perpetuate endometriosis?
So it's a good question, cure and treatment, because you're right. Yes, we can cure endometriosis, I suppose, but there is a high recurrence rate. And what are the factors? I suppose, if you leave something behind and if you don't complete the surgery, then obviously there will be recurrence. So it's very, very important to try to debulk or remove, excise, or ablate all endometriosis, so destroy everything. And as I said, it's very important, and it's evidence-based, that giving hormonal medication, either the pill or the Mirena, if it's an acceptable option, because as I said, a lot of women will want to try for a baby straight away, which unfortunately won't be an option. Then we know that the recurrence is reduced. Now, yes, it's unfortunately it's very common that we have women that have been operated 5 times and 10 times, and you've got extreme cases where they have so many surgeries.
Thank you. One more question. It says, how are findings of endometriosis in totally unrelated parts of the body dealt with? If surgical removal is too complicated, is there another way of treatment?
I suppose there's not the options are the same. It's either surgical treatment. So surgical treatment can be done. You can have deposits of endometriosis up to the diaphragm, and you can remove it surgically during laparoscopy. So you can remove it surgically in many locations. You can have endometriosis in the cesarean section scar, and therefore you can do some surgery there to remove it. So yes, usually surgical, but as we said, because it's a hormonal process that works, that is affected by estrogen. Again, treating it with hormonal medication like the pill should do the trick, or at least get you on top of the symptoms.
Perfect, thank you.
And I have a question. So you said for the C-section scar, so is it for the woman with endometriosis, is it better for them when they're pregnant to deliver vaginal, like not C-section, or is there a preference or no?
Yeah, so it's a good question, and we actually did a case yesterday with a cesarean section scar endometriosis, and I've got, we published a few papers on it. First of all, it's very rare. It's very, very rare. So you will never decide normal delivery or cesarean section because of the risk of cesarean scar endometriosis. And it's extremely rare. I mean, we do cesarean sections every day. It's extremely common. There's thousands per day, and of course, you get very, 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 very rarely scar endometriosis. So the fact that this can happen very rarely should not in any means, by any means, have an impact on the mode of delivery when someone is pregnant. Essentially, if you need cesarean section, you should have cesarean section, and please don't worry. You should worry about many other things of not having the cesarean section, rather than worrying about scar endometriosis if you have a cesarean section. Does that make sense?
So the risk would be the same as a normal pregnancy. So as in the same, like if a normal woman would decide vaginal or C-section, it would be better for her vaginal. If there was no other risk factors, like for a normal woman who's pregnant, it's always preferable for her to have a vaginal delivery than a C-section. And that's the same for endometriosis.
Absolutely, absolutely, exactly, correct. So essentially, the risk of scar endometriosis should never be in the picture.
Yes.
When we are deciding about normal delivery or cesarean section. So if there are indications for cesarean section, please do it rather than worrying about something that rarely, ever so rarely happens. Yeah.
Okay, and also for ovarian cyst, you said that the woman who had torsion, you did a CT scan. Is that routine, or could you also do ultrasound if it's very painful?
Right. Very good question. So the reason this patient had a CT scan was because she was initially admitted and seen by the surgical team, the general surgeons. So the general surgeons tend to do a lot of CT scans. While if we saw this patient first, we would have done an ultrasound scan ourselves. The reason it's quite common to see a gynae patient that has been seen by surgeons before, because you can imagine, the symptomatology is very similar. So if the patient came with right abdominal pain, usually the surgeons will see first to rule out appendicitis, because it's much more common than a torsion ovarian cyst. And at that time, unfortunately, the patient would have had a CT scan, which, as you know, involves radiation. So it wouldn't be the modality that we use as gynecologists, and of course, as gynecologists, as opposed to the surgeons, we do our own scans, and we have radiological skills, so we play with the ultrasounds. So
and what's the time frame? So from when the ovarian is torsion till it's dead?
Yeah. So there is a rule of thumb that they say about 12 hours, 12 to sort of 18 hours. So once you admit the patient and you worry about ovarian torsion, you need to operate. Now, unfortunately, this woman was having pain for 5 days, and she only came to the hospital, on the 5th day. So it was late. However, that's the rule of thumb. It doesn't mean that you're not going to go in, because you can not just assume that this ovary is dead. You have to go in and try to save it. And of course, and most of the times, actually, even days later, we go in and we find that the ovary is fine and we just detort it. But unfortunately, she was unlucky for her ovary to be completely non-viable.
Yeah. And last question. So if there's no torsion, how big is the cyst before you operate? So if it's like 5 centimeters or larger?
Yeah. So as I said, we tend to manage. Again, it depends on the pre-op assessment and on the clinical impression that we have. If I think that it's just a simple cyst and it's 5 centimeters without really any symptoms, then we wouldn't normally operate. If we're talking a simple cyst as 8 centimeters with symptoms, definitely we recommend operation. 8 centimeter simple cyst, no symptoms, we will offer surgery, but we can be relaxed. If it's some other, it's not a simple cyst, it's an endometrioma or a dermoid cyst. So again, it depends on the nature of the cyst, which we can have a good idea pre-operatively by ultrasound, and of course, individual care to the patient if they're having symptoms. Again, their age, their fertility status. For example, if you have someone that is 45 years of age and have had 3 children and she's not really bothered about her fertility, you can be a bit more relaxed that you can not necessarily remove the ovary. You don't want to remove the ovary, but you can do cystectomy where you will be a little bit more radical and maybe ablate more and be a bit more destructive and so on. So every case needs to be treated individually.
Okay, thank you.
So size is one criterion.
Mm-hmm.
Thank you very much. We have one more question in the chat, in the comment box. Do you have lots of cases of extra-ovarian endometriosis? And do you mostly diagnose the extra-ovarian endometriosis by transvaginal ultrasound or MRI?
Yeah, so that's what we said. So ovarian endometriosis, so endometriomas are very easy to diagnose with an ultrasound scan, and it doesn't require significant expertise. It's an easy diagnosis. The extra-ovarian endometriosis is more difficult and way more difficult to diagnose. You can certainly have some elicit some signs when you're doing an ultrasound scan, and as I mentioned, to assess for the mobility of the uterus against the bladder anteriorly or the bowel posteriorly. You can see rectovaginal nodules or endometriosis in the rectovaginal septum, but this is advanced scanning. But we, as gynecologists, we do progress in our training in ultrasound. The resolution of the ultrasound scans are getting better and better. We do find that these diagnoses are made with an ultrasound scan more and more often. But yes, in a non-expert environment, in a secondary or even in tertiary unit, you will probably need an MRI to diagnose this deep infiltrating, as we call it, endometriosis. And yes, we do have a lot of cases. Yeah, I wish I could show you more, but yeah, there's a lot of cases.
Thank you very much. I actually have a question myself as well. What are, like you mentioned that there's around an 8-year timeline between the time of the symptomatology, I think, until the time of diagnosis. What factor do you think plays the biggest role in this delay in the diagnosis? Is it the patient? Is it the physician?
I think it's the patient. Well, no. So yes, it's the patient, but it's us. It comes back to us as a patient, society, and us doctors. So that's why we talk about awareness. So I think once the patient comes to the hospital and goes there to their GP, or then certainly once they go to their gynecologist, there won't be a problem in diagnosing endometriosis. The problem is the awareness. So we as doctors, we don't talk about it much. We don't. There's no much awareness. In fact, there is awareness now. There is efforts. It is fashionable. People talk about endometriosis for the last few years, but I have seen. So we do say, you know, but so hopefully this is changing. But yes, I think that the biggest challenge, the biggest hurdle is awareness. So awareness starts from us, and of course, the patient to receive that awareness and seek medical help. So, and as I said, I think once you seek medical help, I think as doctors, certainly as gynecologists, but even as general practitioners, they will have high index of suspicion. I would like to think.
Thank you very much. I think
I also have a question. Yeah. First of all, thank you so much for the lecture. It was like very useful for me and very interesting. I have a question. Like after the surgery that you showed us on the video, the ovary looks like very sick and damaged. In potentially in how many months or weeks will the woman start ovulating, potentially to start trying for the baby? Because a lot of the times women come, at least when I was doing a practice in the hospital, women are coming for the fertility problems.
Yeah. So there's no, yes, it does look, obviously, yeah, during surgery and of course during laparoscopy, everything is magnified and everything, you can see so many things in great detail. Yes, it does look inflamed and damaged. Of course, it was the case to start with, in the sense that, you know, the endometriosis is an inflammatory process. There's no timeline when you should start to conceive. I think the answer there is whenever you want and whenever you can. Obviously, you will not it will take a few weeks for you to be physically be able to try. And of course, the other thing is it depends how what's the hurry to do it, in the sense that, because as I said, we do advise to give hormonal medication for a few months, just to keep things down, because we have seen that this can reduce the recurrence. But no, that ovary is functional and it's good to go, essentially, as long as your body allows it.
Okay, thank you so much. And the other question is about like fibromas. I mean, the fibroids, the leiomyos.
Yeah.
As far as I understand, they're not malignant and they will not transform to malignant. At least that's what we studied in pathology. So what's the point of removing them if they're not malignant?
Yeah. So first of all, it's strictly speaking, yes, of course they are not malignant, but they can undergo what we call sarcomatous changes. So they can become cancerous, but in extremely rare situations. That's one thing. So it's fair to say that they are benign, because they are benign, and when we counsel patients, we tell them that they are benign. But strictly speaking, there is a very, 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 very small risk of cancer. That's one thing. Now, why operate them? Because you have symptoms. It's a good question, because yes, because you have fibroids doesn't mean that you need to have an operation. We're not operating. We are not operating on fibroids because they actually have fibroids or because they have symptoms. What are the symptoms? Heavy menstrual bleeding, debilitating heavy menstrual. When I say heavy, I mean a woman that comes every other month in the hospital to have blood transfusion. A woman that is collapsing in the street. Unfortunately, we see it very, commonly. So that's, symptomatic anemia that can be caused from fibroids, from heavy menstrual bleeding. And as I said, depending on the size of the fibroids, it can cause pressure symptoms, abdominal pain, pressure on the bladder, overactive bladder, pressure on the bowel, constipation, can affect fertility as well in certain cases. So it's not the actual fibroids, it's the symptoms that we get or you may not get from the fibroids. And that's why I'm saying they're very, very common, and you don't need to have an operation unless you have symptoms.
It makes sense. Thank you so much.
Perfect. Thank you. So unless we don't have any other questions, I think we can thank Dr. Halazis for joining us today and giving us this very interactive and interesting lecture. Thank you for your time and your effort. And thank you to everyone else that has joined us today. Other than that, please don't forget to fill in our feedback form. It's very helpful for us to make our lectures more interesting or educational or whatever audience prefers. So yeah, thank you very much. We wish you a great rest of the week and stay healthy and safe.
Thank you so much.
Thank
you.
Have a good week.